Welcome to the Oxygen Alliance YouTube channel, where we bring you videos on installation, maintenance, and various trainings on oxygen equipment and devices. If you have comments and or questions, drop them in the comment section below or write to us, info@oxygenalliance.org. Remember to like our videos, subscribe to our channel, and hit the notification bell.
Hello everyone, welcome to another session of the Oxygen Alliance webinar. My name is Mwavi Lungu. I'm very happy to be hosting again after a very long time of operating behind the scenes. Today we have a slightly different session from what we normally have. Normally we have a topic that we focus on, and then we have a Q&A session at the end. But as for today, we have invited special guests from the Association of Biomedical Engineers from Kenya, and we'll be having a panel discussion with the different esteemed council members from the association. But before we jump into the panel discussion, the association has a presentation that they are going to make, which is basically going to serve as an introduction of the entire council members that are with us on the call. And then after that, we are going to jump into the panel discussions. And I am joining from Lilongwe, Malawi, so please just make sure you also type wherever you're joining from into the chat so that we know wherever you are joining us from. If we still have time after the panel discussion at the end, we are going to also have a Q&A session. So if you have any questions along the way for the panel discussion that we are going to be having, please make sure that you write them down so that you don't forget them along the way. All right, so at this juncture, let me pass the floor on to the AMEK chair, who is going to introduce himself and then also introduce the other council members. So over to you.
Thank you, Mwambi from Malawi. It's good to have you in. My name is Simon Mbaka, the Chairman, Association of Medical Engineering of Kenya, in Nairobi, Kenya. So I have council members here. Okay, basically that's the part of the council members. We are usually 11. Let me just take you to the presentation. That's next slide. Okay, so basically our association is Medical Engineering of Kenya. It's a national professional association registered under the rules of Kenya. We are located in Avi House. That's the headquarters of the Ministry of Health. And our email is there. As you can see, AMEK Kenya, and then info@amek.org.ke. Next slide. We have a vision to be an association that promotes safe, efficient, and cost-effective healthcare technology management globally. Then we have a mission, next, to promote development of the art, science, and practice of medical and hospital engineering to enhance high-quality healthcare technology management through continued education, capacity building, research and development, innovations, and inventions, among others. Next. We also have a motto that is strengthening healthcare delivery services through appropriate technology. Then our members are drawn from biomedical engineering professionals working in different healthcare services. That is public, private, faith-based, non-governmental organizations, calibration centers, professional training institutions, among others, including diaspora. Okay. Then how are we structured? We have the Ministry of Health, which is basically its work is just which carries most of the members. Then we have basically this slide is just talking about where our members are coming from. Yes, it's just a summary of where we are drawing the members from. So I think we just go to the next slide. Then, of course, Minister of Health, as I said, we have the head of Medical Engineering Technologies Unit, who is Junior, and their work is just to do policy matters at the ministry and offer guidelines for the profession. Proceed. Then, AMEK governance, we have a council, like the ones I've just mentioned. Then we have the executive, Then we have partners like Oxygen Alliance. Then we are guided by through our constitution. Then we have committees. And of course, we have a secretariat and headquarters in the Ministry of Health. Then we have representatives from all Kenya has got 47 counties. So we have got a representative of each county, one, who supports the association in managing the issues of the management. Then we have other members from national referral hospitals, that is Moi Teaching Referral in Eldoret and Kenyatta National Hospital. Then, of course, training institutions, and then private faith-based organizations, so NGOs, and calibration center. Then you have a national government representative that makes sure our issues are treated at the national government. Yes. Next slide. So the team I introduced is just basically this team. That is the chairman, vice chair. At the start, we started with them. So it's just how it is stipulated. Proceed. So the committees, we usually do our activities through committees. We have Education and Professional Development Committee. We have ICT, Publication and Marketing. We have Ethics and Welfare Committee. That is doing a very well job. Then we have Innovations, Research and Development. And then we have Finance and Administration. And of course, we have a monitoring and evaluation team that oversees all these activities. So those are basically the committees that help us run the association. Then the biomedical engineers categories, of course, is the degree holders, higher diploma holders, and certificate holders. And the AMEK usually encourage people to go continuous and pursue education. That is because technology is dynamic and it's changing every day. So we need to keep on going to school. Proceed. The categories of membership is we have ordinary member, we have honorary member, we have corporate, we have fellow member, we have associate, and then lastly we have a student membership. That's just for the membership of the association. Proceed. In biomedical engineers, we have most of them working in Kenya, others working in most areas in East Africa, and others in Africa in general. Then we have others who are distributed in America, Asia, Europe, among other continents. We still have to get more data on this. Yeah, but there are members in these other continents. Proceed. So our core mandate is to ensure that there's availability of proper functioning and safe medical equipment in healthcare facilities to enhance provision of quality healthcare to citizens. But how do we do it? Next, we do it with our core functions. That is, one, to promote and develop the professional status of its members. We have to promote the professional status of our members. Two, we have to do awareness. Three, we have to organize workshops and seminars. So next, then you have to collaborate with the Ministry of Health for the on issues related to this profession, and of course collaborate with the training institutions to ensure that our aims are articulated. Then number 6, to collaborate with organizations to improve management of medical equipment through capacity building and skill development for our members. Proceed. Organize skill upgrading courses. 8 is we publish magazines. Then 9 is we can do anything else that we feel is better, including advising the government on how to ensure that our issues are well articulated. And of course, the last one is we take care of our members' welfare. Yeah. But there are issues that we have not realized. One, we have not able to develop and adhere the standards for certification of our members. Yeah. We are not able to. We have not yet come up with the standard specifications for healthcare equipment that are appropriate to the health center. We still have a long way to go. Then, of course, we still don't have a regulatory body. Yeah. We are members of International Federation of Hospital Engineers, International Federation of Medical and Biological Engineering (IFMP) that we had the last conference last year. Then South Africa Federation of Hospital Engineers. Then, of course, Association of Professional Societies of East Africa and Federation of East Africa Hospital Engineering Associations. That is basically for East Africa, Uganda, Tanzania, Rwanda, Burundi, and others have not yet joined, like Congo and Somalia and Ethiopia, still on the course. Okay, next. So what are the gaps in biomedical engineering? We have several gaps. One, there's technical skills competence is inadequate. It's that inadequacy because of course the technology is changing every day. Then another thing is when our people graduate, they are not self motivated because the market seems to be flooded. 3 is a lack of appropriate tools and knowledge on application. You find that even if when you're working, you don't have the requisite tools to be able to enable you perform your jobs well. Then number 4 is entrepreneurial skills. We've trained our members, but they are fearing to take risks to do business. So we need to have programs that ensures that our members are well equipped with this information. Then documentation, of course, we have issues in inventory because the documents we are using were developed 20 years ago, and things have changed with the time. So we need to upgrade these documents so that we're able to report appropriately as by today's status. Okay, next. What are the gaps in oxygen management? Of course, one, there's a problem in the oxygen accessories management. We need capacity building on this, not only to biomedical engineers, but also to other users. 2 is safety in oxygen management and appropriate PPEs. This one is another challenge because the safety aspect should be taken into consideration, and all efforts should be brought to ensure that this is applied to the letter. Then, of course, medical equipment, oxygen medical equipment management, such as the patient monitors, anesthetic machines, filters. So there's a lot of capacity building that's required on this equipment. Okay, continue. Why we need to do this capacity building on this equipment is to avoid wastage of oxygen. Yeah. Then 4 is purity, oxygen purity testing and use of oxygen analyzers and purity sensors. It's still a challenge because we are not able to get analyzers to most of the hospitals. We need to have hospitals having these analyzers so that they're able to do their tests on their own and able to confirm what they're giving the patients. Then, of course, number 5 is oxygen cylinders, transportation and storage at facilities. You realize that there are so many schools of thought on how to transport oxygen cylinders. So we need to have a standard way on how these cylinders should be transported and stored, because you realize there's the various school of thought are giving information that is somehow contradicts. Then number 6, as I said, documentation and reporting of oxygen systems works so that we're able to get the right information. Proceed. So as an association, we also have challenges. But what are these challenges? We have internal. And one of internal is you realize that our membership, the number is high, but the participating number is less. So that's a big challenge. So that brings again the issue of subscription. That means our resources now becomes bigger, because even as I told you, the country is divided into 47 counties. So you realize all the counties do not remit the subscription, which are already deducted from our members. So it becomes a challenge. Of course, the other issue is insufficient number of partners. If you could be having like 10 partners, then each partner takes a particular activity, then we'll be able to do so many activities. Because like now, you can see Oxygen Alliance is there. But even if it is there, we still need others to do other things, because we need to do so many issues, so many programs. Then, of course, networking is a challenge because the email sometimes they bounce. You realize that our members are busy, sometimes don't want to read emails. So it becomes a challenge. And of course, there is a lack of capacity in use of the communication tools, the Facebook, the Twitter, LinkedIn, Instagram, among others. So it's like we need a package and then roll it and pass it to our members. Maybe Oxygen Alliance, this can also be a very good area of catch, because if members are don't have this information, then even attending webinars becomes a challenge. Of course, the website, the same thing. People are not able to log into the website and learn information, get information from the website. Then you have also newsletters. We are not, when you ask for articles, perhaps it takes too much to get articles from members. Then, of course, we don't have a union. The union is there, but still there are challenges here and there. Then, of course, members not taking being active in AMEK events, and this is a big issue. I think there's some motivation somehow. Okay, then external is I told you we don't have a regulatory body, we don't have a national healthcare technology policy for the medical equipment. So these are key issues that we need to see how we can go about it, because without a regulation, without a policy, it's still a challenge in managing these issues. Then, of course, inadequate training and exchange programs in the profession, in equipment management and oxygen systems. We don't have much on this. Then, of course, a lack of proper structure in the Ministry of Health regarding the management of the biomedical engineering. Next slide. Of course, the other issue is the training institutions. They have become business centers. They are not doing the problem solving or producing people who are ready for the market. They are producing people, then they bring those people to us again to train them again, which is a big challenge. Then a poor working environment. I said, if you try to work in the hospitals, you'll be surprised how our members, the environments they are working in. So it needs somebody to be touched and come and do a miracle in these hospitals. Then, of course, I told you that the trainings, the members, the training institutions are doing a lot of training. So the outcome of the trainees they are mass. They are producing mass people. That is what, not mass people. They're doing mass production. So when you do mass production, what happens? In effect, there's no absorption. So it becomes, now it brings another problem. There's no employment. And then people start asking, what is the association doing for us? Because there are many out there, and the market is not able to absorb. Then, of course, lack of political will to support the profession. Yeah, proceed. So then we have a solution for this. One of them is we do effective communication, capacity building in ICT social platforms. Then I do aggressive recruitment. Even if you do aggressive recruitment, again, retaining is a challenge. Then prepare proposals, trainings, and others, so that we are able to, the people who come out of colleges, they need to be trained more so that they are able to be acceptable in the market. Then members should be committed on subscriptions, that's the payments, so that we are able to have resources to run the association. Then, of course, implementation of documentation of activities. So when you do document, then you need to ensure that they are right. Then, of course, the external one is the training institutions should strengthen research, do innovations, emphasis on problem-solving techniques, then inventions, innovations, and all that development. Because you need to see products getting out of the colleges. Then having the medical devices management policy in place, which we don't have. Then having a council, it solves this problem. Then, of course, capacity building of our members. This will give power and creation of people to our members to be able to participate in most of the activities. Okay, continue. Then you need to do monitoring and evaluation of our performance. Then you need to partner more with stakeholders. I said that. Then having continuous professional development so that we're able to track our members. This should be on track because there's a challenge already. Then enhance skill upgrading courses to address the pertinent issues that are already in the market. Then, of course, to have an oxygen system management, all are package inclusive. That is, the system is there, people are trained, both so that we don't have wastage, all that. Continue. Okay, yes. The role of biomedical engineers in Kenya is ensuring that working environment and tools, biomedical engineering institution, this is just a scope. Then so let's just proceed. So the role of biomedical engineers is to manage the life cycle of medical equipment through appropriate selection, appropriate technical specification, commissioning, training of user and technical training, adherence to preventive maintenance and corrective maintenance, then decommissioning. That's the key role. Proceed. Then the working environment, you realize that workshops should have an office, should have a boardroom, should have test rooms for that, should have working tools, should have protective clothing, should have some test tools and analyzers. These are just basics that we need to have them in our workshops. Proceed. Then how we are distributed, you realize that the Kenyan system, how it is distributed, that we have level 6, we have level 5, level 4, level 3, then level 2. But you realize the distribution of, according to WHO, level 6 should have at least 30 biomedical engineers. Level 5 should have 16. Level 4, 7. Level 3, 2. But you realize when you come to when you go to the site, the results are surprising, because you realize at level 6 you perhaps you find 20, level 5 you find 8, level 4 you find 2, 1 or 3, level 3 you find none. So that's compromises the overall quality of care. Proceed. Yes, I think this I've already mentioned. Proceed. Then the areas of concern. You realize that there are some areas that we don't have partners to take care of areas that need also attention, because when you are working in hospital setup, they think they are marginalized. So we need partners to take care of maternal care equipment, theater equipment, ophthalmic equipment, ENT equipment, physiotherapy equipment, dental equipment, and very seriously on energy audit management. So these are concerns to one on that. But now when you do this with partners, what do they benefit? Partners with AMEK, they do exhibition, their market is open, there's that communication, and then there's neutral sales environment. Proceed. Then there's a fast and easy market penetration. There's international market penetration. Then members are able to know the truth. Then, of course, you do presentation to the AMEK audience. Yeah, proceed. So, but when you do all this, what are the outcomes? The outcomes are that we have improved healthcare technology management. We have improved healthcare service delivery that is safe, economical, and reliable. We have prolonged medical equipment life cycle with reduced cost of maintenance. We have skilled and motivated personnel. We have reduced mortality cases related to medical equipment performance. Problem solving becomes simplified. Then, of course, there's technology advancement in the profession. And of course, the partner is able to penetrate to the hospital, to the health institution easily. Proceed. But members, what about members? Members, they bring synergy. We are able to share information. We are supposed to do networking. They are able to do capacity building. Then, of course, even themselves, they get the job market easy presentation, because it is easier to know the biomed at such a point need a job, so it's able to be absorbed. Then, of course, the reference point. You say you're a biomed, you're a member of AMEK, you are able to get that as a starting point. Then, of course, you become recognized globally. Like now, if you are here, Oxygen Alliance are able to know you. Then, of course, professional protection. You are protected and you grow together. Then, of course, when you're in an association, you are at home because you are with your brothers and sisters. Proceed. During COVID, AMEK was very relevant because of sharing information on oxygen management. And this one actually made us be known, because we really advocated for this. And the OSG was very good at this. So I think I felt it was good to mention that. Proceed. I think that's the end. Yeah, thank you. I think that is all.
All right, thank you very much, Simon, for that very comprehensive presentation. There are a lot of very important issues that you have discussed there. I was particularly drawn to the issue of regulation that you pointed out. I think this is a challenge in most of the low and middle income countries. So this is something that we really need to be looking at. Also, if you look at the issue of distribution of biomedical engineers, as you also pointed out, this is also a very big challenge. Even here in Malawi, you find that the different levels are not getting the biomedical engineers that they are supposed to have. But these are the type of environments that we're working in, and that's why we have these associations and such platforms so that we can help to try and bridge these gaps. All right, so now we'll jump into our panel discussion. So as I pointed out at the beginning, I have prepared a couple of questions for the council members. So the way we are going to do this is that I will ask a question to one of the council members, and then if another council member has a comment that they need to make on the question, you are also welcome to come in and then build on the explanation that the other one has worked on. As for the audience, I think let's reserve all our questions for the end, because we are going to have a Q&A session at the end, because right now we want to learn more from the council members. All right. So since we already had Simon kickstart the conversation, let me direct my first question to Engineer Millicent. I don't know if she's here.
Yes, I can hear you, but unfortunately, I'm in some place I traveled and my network is a bit unstable. But please just carry on.
So Simon, can you just share with us a particular impactful experience that you have had working as a biomedical engineer in a low resource setting, and how did that shape your approach to the different healthcare solutions that are there?
I think maybe I think as I said, the role of biomedical engineers is to ensure that the equipment are optimally working well. In most cases, we have been called to say when the clinicians are stuck or they are unable to do their procedures. So you do something that enables them resuscitate or able to revive or bring back a life that was perhaps almost going to get lost. So that role, that action alone brings motivation and ensures that somebody is happy when you after you do the job. Yes. So
Yeah.
the response are able to sort an issue that has already been raised becomes a motivation on its own.
Yeah.
And that's it's impactful because even the clinicians, when you leave the facility where you're working, they are able to solve their problem. You leave them smiling also. So it's impactful positive to their work.
Yeah. Yeah.
Yeah.
That's great. So what are some of the common challenges that as biomedical engineers we face in low resource settings? Like for instance, for the case of Kenya, what are some of the common challenges that biomedical engineers face?
Thank you so much. So thank you, Simon, for the comprehensive presentation. So some of the challenges that biomedical engineers experience in low resource settings are really many. And one of them, I would say, is working environment. Kenya and even other African countries included, you realize that most of the facilities do not set aside a biomedical engineering workshop where biomedical engineers can be able to carry out planned preventive maintenance or even the corrective maintenance or any other activity that is related to the medical equipment. So the biomeds are left to work on the corridors, probably in the wards, or anywhere they find probably appropriate as at that time. So for me, this is such a big challenge, and it's also coupled with lack of tools because even if you buy tools to the biomeds, they do not have a place to keep. And so I find this to be very, very demotivating environment to work in because you realize whenever a doctor is hired to come in, the first thing they are given is a stethoscope. But when a biomed is hired in a facility, never given work tools to be able to do their work. But then somehow they're expected to deliver the same way a doctor is expected to deliver. And so it becomes really, really challenging to, to deliver what you're expected to do. And maybe just one more challenge to add apart from that is in the low resource settings, we have not come to the realization of having standardized devices per facility. So let's say a case of an oxygen concentrator. You will find one facility having like even 10 brands of oxygen concentrator. And the biomedical engineer will find themselves having a lot of headache managing the spare parts, accessories, and the consumables for these concentrators because they are different. So spare part management become really, really tricky because of non-standardization of the medical devices across these countries. We really have quite a lot of challenges, but allow me to stop there with the hope that you have been hearing me. I'm so worried about my internet. Thank you. Over.
Yeah, thank you, Millicent. We heard you very clearly. I think your network is stable now. Indeed, the issues that you have pointed out are a challenge in many of the low resource settings, like the issue of the different models of concentrators that you're pointing out. Here in Malawi, the assessments that we were doing, we came across more than 85 different models. So you can see that it becomes very challenging for these biomedical engineers to handle this equipment. And Millicent, maybe just to pick up on the same, how have you or the association tried to overcome some of these challenges that biomedical engineers commonly face?
Yes, so as the association, we have done quite a lot, and it's not done yet. We are still doing quite a lot. So one of the things that we have been able to do is constant advocacy for the right standardization of the devices. One of the things that we are working on, and we have been really trying to push the Ministry of Health to have, is having standard specification through our procurement bodies called KEMSA for the government. And in Kenya, health system is devolved, and at times you find we have national government doing procurement to their own, and the same you'll also find county governments doing procurement to their own. So what we are doing as AMEK is to advocate for having standard specifications of these particular devices, so then it is easy for the biomeds to be able to manage. The second thing we do, I know as an association, there's a bit that we are expected to do, and there's a bit that we cannot be able to do because we are not a regulatory body. But we find ourselves really pushing at the right tables. You find us sitting with the right people to advise. We find ourselves in different technical working groups. We force ourselves there so that we can be able to speak at the right table. Because we also noted that if you do not speak it out at the right table, then it will be taken as noise. So we have been setting ourselves to work with different partners and form different technical working groups to be able to standardize some of the areas where we feel are really lagging behind. And like the priority we are giving this year, we are currently working with different partners to revise and revive some of our health technology management guidelines, which will be able to streamline the areas of device standardization. Another thing that we're also working on is ensuring that the biomeds at the facility level are given a lot of empowerment to be able to voice out, even at that level, because association in itself, having only a leadership of 12 people and overseeing the entire country, may not be able to penetrate into the villages and even the village hospitals to voice out. So we are trying our level best to empower the biomeds with a lot of knowledge of what the global standards are. So then even at the village and at the very small hospital level, they can be able to speak up on what exactly is required. So again, just to sum up what we are doing as an association, we push ourselves and we find ourselves in the different technical working groups that are relevant to the biomedical engineering and health technology management. We do a lot of advocacy. We call for media briefings when things are not going right, and we shout out to the government to listen. We also empower our biomedical engineers to be able to voice out what is required as per the global standards. I think I can sum them up into 3. Thank you. Over to you.
Right. Thank you very much. I think that was a very comprehensive response. So my next question, I think any of the other council members that are here can take this up. I was just also looking at the AMEK website, and one of the areas that was pointed out there that you also work on is in the area around innovation, research, and professional development. So can you just share with us some of the recent innovations in biomedical engineering that have had a significant impact in Kenya? So I'll leave this one open to any of the council members to pick it up. And please switch on your video when you're responding so that at least our audience can also appreciate who is responding.
Thank you so much, Mwabi. And allow me to apologize once again for not switching on my video, because I'm in a place that I know once I switch on my video, I'll not be able to be audible. So allow me to continue. Thank you.
Please continue.
Yeah, so one of the areas that I know we haven't really done so well, and I'm being very honest here, is the area of innovation and research. And we are really struggling to see how best we can be able to fit in. However, that doesn't mean that we have never had innovations and research being done. There's quite a lot that is going on. I will give an example of during COVID-19, we had TIBA-Vent, a ventilator that was innovated by the students at the Kenyatta University, and it went through various stages and approvals in the country. But unfortunately, I think it never passed the clinical trial at one of the referral hospitals in the country. But I would say that was one of the best innovations that we ever tried as a country. And we were able to showcase that Kenyan biomeds are actually able to do quite a lot more than we think. The other area that we've also tried to work on is oxygen concentrators with the University of Nairobi, whereby the students have been able to work in collaboration with the University of Nairobi to be able to come up with some of the, sorry, not oxygen concentrators, but suction machines. Apologies. Yeah, so those ones were brought up and they were able to do that, and they're actually in use as we speak. And so we haven't structured it as an association, but we are called in to support whenever there's any other. But one of the areas that we are having as a strategic plan for the association is to set up a very robust committee supported by a partner that will be able to support the area of innovation. And we are looking at that because we also realized that when it comes to the continuous education, whereby we are giving the CPDs, we have also lagged behind. So I can confirm in this meeting that we had a last meeting last week where we discussed these two particular areas because they go hand in hand, that we really want to see how best we can work on this area that has been lagging behind, especially considering that now we have AI doing almost everything. So this is an area that if there's any thoughts, we'll really be happy to partner, and we'll be happy to, to borrow from any insight in the group. But those are the areas that I can say we have supported as an association. Thank you. Over.
Okay, great. So I know you pointed out that the project that the students were working on didn't go that far, and we know that when we're working on different projects, there are always risks that are associated with development and implementation. How do you strike a balance for the need of innovation and practical limitations and risks that are present in low resource settings? As an association, how do you help either students or any biomedical engineer who is trying to come up with different innovations to strike a balance between the innovations that they are trying to come up with and the practical limitations that may be there and may affect the implementation of the innovation?
Yeah, so maybe I can say something, then probably one of the council members can add. And so one of the ways we support the members, and again, as I said, we have not been very vibrant on this area, but one of the ways I know we have supported our members is to connect them or link them up with the partners who are able to support them with resources, because the biggest challenge that the students are having is lack of finances to be able to import some of the parts that they're using for their innovations. So I know we've had 2 cases whereby we have supported, that is post COVID-19, we've supported 2 members we've linked 2 members with the partners, and they were supported with the finances to be able to, to purchase what they wanted. However, again, we have not seen the products, getting to the market because of different approval steps. So in Kenya, we're still lagging behind when it comes to the technology approval. Though right now, I would say that the current government is very keen on the manufacturing. And that's why I was saying in our last meeting last week, we were just finalizing, and one of the things on supporting these local innovations and manufacturing. As it is now, I wouldn't say we really have a very structured way. It's something that we are working on. Probably at the end of the year, we'll be able to say now we structured it and we've been able to do 1, 2, 3, and 4 for the students who are having innovation projects. Yeah, thank you.
All right, thank you very much. I think that is very clear. So you pointed out that one of the ways that you are trying to help out, push out these different innovations that are there is by having discussions with government and the other different stakeholders. So in your experience as an association or as individuals from the association, what strategies have proven effective in fostering collaborative relationship between the biomedical engineers and either the government or the hospital administrations or even training institutions?
Good question, Mwabi. So one way, and this is very interesting, that one of the best way to have this work is, first of all, have one of the officials come from the Ministry of Health, Biomedical Engineering Division. That is a clear way. So with that, you can be sure that any issue you raise at any meeting, however small it is, it will actually be with the government, because you're having one person from the Ministry of Health being a member and an official of the association. So that, I think, has really, really helped us along, even to penetrate through different offices within the Ministry of Health. Another way is being very, how do I say it? Being very resourceful in terms of information. The Ministry of Health or the government, and not only in Kenya, do not know what biomedical engineering entails. They wouldn't know probably the specific nitty-gritty needs of an oxygen concentrator, or even the oxygen guidelines that are required in the country. So we try as much as possible to compare notes and research on the global standards. So by the time you're presenting something before a minister, it is something substantial that next time you knock a door, they are running to open for you the door. The challenge comes in when you get in and you don't have point and facts to put across. So we try as much as possible to really benchmark with the global standards in whatever we are talking about, so that at any given time you're on the table, we are at par or ahead of what the ministry is thinking about, and so we become the advisors by default. So I would say that has really, really worked. And at some point when they have blocked their ears, again, as I said, we call for the media, because it's rosy as long as it's rosy. But when I don't have oxygen in the facility and patients are dying, I will not go and sit down on the table with the minister. For us, we call for media briefing and we make noise and they will act. I think one thing that the government fears is publicity, negative publicity. And not in a bad way, but speaking facts that, look, we do not have oxygen because of 1, 2, 3. I don't have spare parts for my oxygen concentrators, and so my patients are dying, or I don't have expertise to have this. So we make a lot of noise at times on media, and at times that is the language that African government understands a lot, especially in this country. Yeah, so I don't know whether somebody else from the council has something to add, but Mwabi, that is what I can say for now. Thank you.
Maybe Mwambi to respond on that, to add on that, I think yes, elaborated very well. Also, when we call for an audience, either the government or any other agent, they are ready to listen to us. So that is an effective way, because once we meet the things we discuss, the only challenge comes to implementation. But being hard and implementation is something and another thing altogether. So they are ready to have a round table discussion so that we chat away and address underlying problem. Okay.
All right, thank you very much. I think it's good that at least you have that influence that the government and the administrations can also listen to what you have to say. So maybe just building on the same.
Maybe
Yeah.
just before you go on the same, I just wanted to add that is not supposed to only happen in Kenya, but I suggest for any biomedical engineer who is actually listening to us today that we need to take our positions and understand it so well that nobody else understands what a biomedical engineer can do but you in that facility or in wherever you are. So having knowledge and more knowledge about what you do is very, very key in ensuring that people respect your position at the table. So it's upon all of us, wherever we are, however small, however big it is, to ensure that we are strategically positioned and we are strategically informed of what we are supposed to do as advisors of the government and even of the organizations where we are. That can really help even other associations that are listening to us. That whenever you take even a report, you've written a report, it has a lot of content with a lot of references that can add value to what the government needs. Thank you. I think I just felt I needed to have that. That doesn't apply to Kenya only, but it can be applied across the African countries where we really have a lot of challenges with them, with the leadership listening to what is on the ground. Over.
Yeah, thank you, Millicent, for that addition. I think that is indeed very true because even like for us here in Malawi, it's just in the past maybe 3 to 5 years that people have actually begun to understand what actually biomedical engineering is and the impact that they have in our health system. So indeed, this is a challenge and something that needs to be looked at not just in Kenya or Malawi, but any other LMIC that is also facing such similar challenges. So in the discussions that you normally have with government or different hospital facilities, are you also involved in or do you engage them in discussions that actually lead to policy changes which can help to improve the work of the biomedical engineers?
Yes. Like I said earlier, this year our main focus is to review, develop, and have health technology management policies implemented across this country in Kenya. Why am I saying this? It's because we've had series of discussions and we have arrived at that level whereby we have to do it. There's nothing else that we can do to have the processes aligned, but to change the policies and revise them accordingly. So to answer your question, yes, we do discuss such kind of policy changes, and that's why we have arrived on revising policies that I think were revised like more than 5 years ago, and some of them have been overtaken by events, especially after the COVID-19 hit. And so those are some of the things that we really talk about. And one major thing that I know is hitting like almost all the LMICs is unemployment, which is very key. So we really, really push to ensure that the biomedical engineers are employed. In as much as at times it might be seen like it's really a drop, but even having 5 biomedical engineers employed in a county takes really a lot of push and letters and making a lot of noise. And at times, you know, you're just becoming a mad and wild person that, look, we really need our devices to be taken care of. So yes, we discuss a lot revolving around policy changes, implementation and development of the health technology management guidelines and systems. Thank you. Over.
Thank you very much, Millicent. Any further or additional comments from the other council members before
Maybe
I proceed to? Yeah, go ahead, Simon.
Maybe to add on that, what SG is saying, it is true. When you engage the ministry or relative agent or the necessary agents, they are able to, like now the issue of the documentation book management guidelines, which is outdated. they are also in agreement that this document is outdated, and it needs to be reviewed. So you find that there's that corrective agreement that we need to work together so that we're able to improve the work of biomedical engineers in the country. So it's a positive response against our request. Yeah.
Yeah, and Moabi, just to add on that, is that we compare what we have with the global standards. I think WHO has given a lot of standards for the health technology management, clinical engineering, and biomedical engineering. If all of us in this particular forum can actually be able to be versed with what WHO advises the countries and the nations to do, then I think we'll be the right people to advise the governments. And even apart from WHO, we also have some other global organizations that are recognized and affirmed by WHO, like the AMI, the ECRI, the GCA, the Global Clinical Engineering Alliance. You know, these are organizations that have been affirmed by WHO that they're actually giving guidelines that can be used to support some of the national guidelines. So again, what I would say here is that let's be versed with what the global standards are. So then by the time you're going to pitch for reviving and implementation of the old guidelines, then you have what exactly you want to change from the national one. Thank you. Over.
Thank you very much, Millicent. I think that is very clear, and it's true that WHO has put out a lot of policies and guidelines that we can actually use to tackle some of these issues, but it's just an issue of us, I think, as biomedical engineers, also need to take that responsibility of looking at these guidelines and also sharing them with different administrations or governments so that at least they can also be put into effect. Let me now jump into maintenance. I think the issue of maintenance culture is one of the things that in most countries, or at least for the case of Malawi, I think it's still something that most facilities haven't fully adopted yet, because most people would prefer to replace equipment than to fix what is already in existence. So as an association, what are some of the policies or that you have put in place or have impacted or influenced to ensure that maintenance and repair is something that biomedical engineers are looking at first and foremost before they can actually start thinking about replacing equipment?
Maybe on that, what we are doing as an association, that we identify areas that the equipment that are really giving us problems, then we do capacity building on that, so that we're able to impact knowledge to our members, that they're able to carry out maintenance. But again, on the same, you realize that there are two schools of thoughts here. There is the private and the government. The government setup on preventive maintenance, they don't take it seriously as opposed to corrective maintenance. Whereas in the private sector, they take PPM, planned preventive maintenance, to the letter, and that's why the difference comes in, because the government, the maintenance cost for PPM is very high, and they are something they are not able to sustain. So they keep on, you work on need basis, break down, revive, as opposed to PPM. Although some are also trying to adhere to that, but not all. So we try to sensitize and do advocacy so that we're able to pass this information that it is good you emphasize on PPM as opposed to waiting for the equipment to break down. So ours is communication, organizing for workshop, capacity building for these issues, so that we're able to ensure that our members are well acquainted to those most challenges. Yeah. Over.
Yeah, right. Thank you.
Thank you so much.
Yeah, go ahead, Vincent. You can comment.
Yeah. Thank you, Chairman. So, in addition to what the chairman has said, At the Ministry of Health, we also have the Equipment Maintenance Protocol Handbook, which was developed some years back and is still in use, but it's one of the documents that we are going to review this year. So this is also a document that helps the facility biomed to be able to perform the plant preventive maintenance. Apart from that, we really advise that whenever a local distributor supplies a device, then one of the things that we ask for is for the training of these biomedical engineers to be able to carry out plant preventive maintenance and corrective maintenance. So proper training and handover of documentation, especially the manuals, is one thing that we really advocate for. And one final thing, because I'm seeing we're out of time, one final thing that we do is that in Kenya, we had this program called the Managed Equipment Service, whereby the national government purchased some devices and issued them out to the county governments. So in those kinds of arrangements, you realize that this outlined service contract that is there between the government and the local distributors to be able to ensure that the devices are managed. So yes, it's not one clear protocol that it is followed 1, 2, 3, but it depends on the situation. If it is a managed equipment service, then there's a service contract. If it is a facility maintained device, then we have the maintenance protocol that is in use, but all needs review. And of course, what the chairman said earlier, that we are doing a lot of advocacy during some of the webinars that we are doing and even the conferences that we organize every year to ensure that biomeds understand the meaning of maintenance, both preventive and corrective, and even also inviting the hospital facility managers to attend our seminars and the conferences so that whatever we talk about as biomeds, they also take it home from the horse's mouth. So yeah, that is what we do as the association. Thank you.
Okay, great. Thank you very much. I see we are running out of time, but I still have two, maybe three questions that I want us to discuss. So maybe through you, Chair, you can advise us if we can extend a bit, maybe with another 10 minutes so that I go through the remaining questions because they are also key questions.
I think maybe we proceed. Just add another 10 minutes because we finish what is on the table.
Unfortunately, I may have to. Sorry, Mwabi. Unfortunately, I may have to drop because I'm having another meeting at the top of the hour. So, thank you so much for the opportunity to contribute, and I believe our able chair, together with the rest of other members, will be able to answer the questions. Thank you.
All right. Thank you very much, Millicent, for joining us and giving us your time, and we'll keep in touch. All right. So moving forward with my questions. So looking forward to the future as an association, what are some of the key areas of focus that needs to be addressed in the different facilities or communities so that we, in order to push the work that the biomedical engineers are doing forward?
Thank you very much. What we are advocating as an association, and we are already engaging the ministry on the same, and they are very positive about this, is to have an internship program. Because I told you the colleges are producing mass graduates, so we need to have, when they come out of college, first of all they go for an internship period, not less than 6 months, depending on the level of training. And this will make them acceptable in the market. And this is the only way to go. And I thank God that the ministry is taking this. This is positive, and they are calling us for more engagement on the same. The other issue is that as an association, we are also advocating. We have an innovation center. This is where we have, if you could get a good partner, perhaps we establish an innovation center whereby we can bring a few minds and then come up with something that can solve a problem in the country. Yeah, so those are the two major issues that we are looking at, and then the other things will just come, will just follow. Yeah.
All right, thank you very much. So before I proceed to the next one, I think Douglas had launched a poll, so please make sure you have a look at that poll and respond to the question that has been asked on the poll. If you don't know how to access the poll, for those of you joining on your laptops, you have the icon on the far right, bottom right of your screen. It's a triangle, a square, and a circle. If you click on that, you see the pause menu listed there. If you are joining on your mobile phone, then click on the menus option. When you click on the menus option, you will see a similar icon, a triangle, a square, and a circle. If you click on that, it will also take you to the pause window. So please look at that poll. It has a question that will also provide very insightful information to us. So Simon, building to the same question, what role do you think international organization and partnerships or collaborations should play in order to advance the biomedical engineering field in low and middle income countries? Or any other council member can take this one up, I guess.
Maybe the international community, the role they can play is to ensure that to help the association in the advocacy for distribution of biomedical engineers at facility level as per the WHO guidelines. That would be one of them, because once you get, it's like holding our hand in ensuring that what you are speaking can reach the authorities. So that is one. They help us advocate for ensuring that the biomedical engineers at the facility levels, the numbers are close to WHO. Another issue is that they can do is that they also help us have effective or good working environment. Because if the hospitals where biomedical engineers are working, they don't have a good working environment, the result is that it's going to impact on poor quality of healthcare. So that can also, if it comes from outside, perhaps it's going to make the management of the ministries see sense in it. Another element is to have introduce what we call benchmarking. Perhaps they could say such people could come and visit a certain country and see what they are doing. So that collaboration, so that when our members go there and see what they are doing, plus our seniors, they go and see what they are doing, they come back here and implement the same. So that would add value to what the association is trying to advocate for. The other issue is the issue of internship, as I said. It's also good because if the training graduates are coming from college and then they are not able to do internship, then the result is that they will not get job market. They will not be absorbed in the job market. But the international bodies can help us in pressing on this matter as well. I think for now, maybe somebody else can say something.
All right. Any additional comments from the other council members?
Thank you so much, Nelson. Something that I just wanted to add on to, in addition to what the chairman has said, is also for these international bodies to ensure that there are those internationally recognized standards for management of medical devices. And I know these are some of the issues that are also discussed even at the global level, maybe where they're having these World Health Assemblies, to also ensure that the member countries, especially in our low and middle income countries, also adopt these policies, so that now you're able to have standard policies and management policies for medical equipment devices management. So I think probably that will help, so that we have standardization, as and also in terms of what the chairman has said, in terms of also benchmarking what is happening in other parts of the world, that probably on this part of the world that probably can also be able to adopt. Thank you so much.
All right, thank you very much, Nelson, for that comment. So moving on, in terms of community engagements, how does AMEK engage with the broader biomedical engineering community to foster a culture of continuous learning and innovation? Because it's not just about repairing the equipment that is there, but you also should be thinking of how best can you come up with new solutions or new technologies that can help to build the field. So how best do you work with the broader biomedical engineering community?
So what we do is that we have WhatsApp groups that we manage at the council for communication. Then we have tasked a few governments who respond to the issues that comes from our members. And I've seen this work very well, where a member is stuck, is unable to move, do any step, and he raises a question that immediately it is responded to and advised, given on ways how to handle it. Another issue that we do is that we do yearly conferences where people come together. Then we do discuss issues. We have a session for discuss issues at the conference. So we hear the issues there and then agree on a way forward. Another element is that we do is that we have a magazine that we do yearly, although we want to make it twice. So in this year, it is a magazine. We also give guidelines on how to do how to manage medical equipment. Yes, basically I think those three, and of course we invite the Ministry of Issues to come and address our members on issues, on also to also listen to us also, and they also talk to us. Then we also involve the local partners to ensure that we have skill upgrading courses or workshops that are able to address these issues, one person per county. Yeah.
All right. Thank you very much, Simon. I think it's indeed great work that AMEK is doing in order to build the biomedical engineering field. So my last question for today, what are the strategies that are being employed to ensure sustainability of the different biomedical engineering projects? I know you have mentioned WhatsApp groups that you have that you use to engage with the different biomedical engineers across the country. What other ways have you put in place to ensure sustainability of the different projects that the biomedical engineers are working on?
The strategy one is that one of using WhatsApp group that I mentioned. The other one is the continuous professional development that we are working on. We are already engaging with the Kenya Medical Training College to start can become as a CPD provider. So this will help us track our members and able to gauge them on yearly basis. So that is one of, in fact, that is the best way to for future. And as SG said, last week we had a meeting with them, and we are here to have a series of other meetings so that we chat way forward on how we can implement this matter. The other element is that we also strengthen our committees. As I said, we have 5 committees and the 6th one for monitoring and evaluation. We want to strengthen this committee so that they are able to, each committee is able to handle a matter on its own, and then we do it quarterly. And then we have every 3 months, each committee gives us a results of what they have done to ensure that our members have been enriched with information and are able to address issues on the ground. And this comes as a way of making us grow, and it's more sustainable than any other thing from where I see it. Thank you.
All right. Great. Thank you very much, Simon, for that. I think it clearly shows the passion that is there to try and help build the biomedical engineering department, or at least maintain high levels of standards in the different areas, not just in maintenance, but also in innovation, and also even the quality of education that the different fresh biomedical engineers are getting. So we are way past time.
Maybe on the same, we have also started a mentorship programs. I had forgotten that. We are going to college talking to students before they graduate, so that by the time they are coming out of the college, they know what they're going to do. So these programs is also a way of preparing them so that they become productive when they go out and they're able to contribute together with other biomedical engineers when they're outside, when they are already qualified. So that's also a way. Also, it's a way of sustainability also.
Yeah, great. I think that's also very important because some students who you find that way after they graduate, they normally don't know where to start from. So I think that's also a very important program that you have introduced. So looking at the time, we are way past time. Unfortunately, I won't be able to take any questions, but you can paste all your questions in the chat. We are going to compile them, send them to AMEK through the chair, and then after they respond to the questions, I think we'll communicate the responses that we'll get back to you. But maybe, Simon, there's a very interesting question in the chat, which I know we are past time, but I think maybe it's something that you can also comment on. The question is from Kataya Banda. He says, how are you managing the issue of internship so that it doesn't compromise employment opportunities, especially for those that may hide behind internship, whilst in reality they are taking advantage of cheap labor? So Simon or any other council members, I think you can take this one up, and that would be our end point.
I think the person who has asked the question, the issue of internship, we have not yet started. It is when we want to start. We are engaging with the ministry because, you know, internship, you are paid. What you do is the internship and the attachment are different. Internship attachment is when is what you do when you're in college, and you return the logbook for a lot of marks. But internship is when you qualify, you need to gain experience, although you are working under a superior biomedical engineer to supervise you, so that you are able to be acceptable in the market. And this time you also get a stipend from a stipend is a small allowance from the employer. So it's what we're trying to engage with the ministry so that we roll it out, because at the moment the only department that is doing the internship, I think it's just doctors and I think nurses. But we also voicing up so that we also fall in the same category. And I can assure you that it is positive. It is coming out positive. And very soon, perhaps maybe by the end of next year, we shall maybe start admitting our own first interns in various hospitals. This is how it will come, is that the institution that are training will have a register with them, and then we will be giving them where to post the interns. So it is not a prerogative of the training institution. It will be a prerogative of the AMEK and the ministry to decide where the students should go for internship. Because again, we must also vet the internship where you're going to do internship. Maybe there is no workshop, maybe there are no tools, maybe there are no biomeds. So we need to see which areas have all these with minimum requirements that you're able to, so that you're able to now impart knowledge to the graduating students. Thank you.
All right. Thank you very much, Simon, for that. And I think also just building up on that, I'm pretty sure there are some labor laws out there which also clearly stipulates where the internship ends and when someone should actually be employed. For instance, like here in Malawi, I think the maximum someone can work as an intern is 1 year. So if you go beyond 1 year, then that person has to be offered a contract or be fully employed. So there are different, there are also some labor laws that have been put in place by the government, which also help to monitor such so that people don't get exploited. All right, so we are way past our normal ending time. Apologies for taking up much of your time than we had intended to. This because of the new approach that we brought in. I think it was also a bit hard to just cut along the way, because there were a lot of important issues that we had to discuss with AMEK, which I'm sure a lot of you have picked up a thing or two from. So for those of you who joined in late, the discussion was recorded, so it will be available on our YouTube channel, Facebook page. So please follow us on these pages, and we are going to post that video there, so you should be able to catch up. But otherwise, you have been a wonderful audience, and thank you very much, Chair Simon and your entire council. It's been a wonderful discussion. I think we've discussed a lot of important issues that have to be addressed, not just in Kenya, but in the different other countries. So thank you very much for your time that you have had. Next time when we ask you to join us for a similar discussion, please join us, because I'm pretty sure there are a lot of things that we can learn from AMEK as an association and you as individuals as well. So thank you very much. So reaching this far, I see a couple of people raise their hands. Unfortunately, I won't be able to get more questions. So please just type your question in the chat. I'll leave the chat open for another 10 minutes so that you can paste your questions. Don't forget your email address as well, because we will need that to send you the responses that we get from AMEK. So I wish you all a lovely evening, and we will see you again in our next discussion. Thank you for joining us, and goodbye.